Ischemic colitis is the most common form of intestinal ischemia, and it behaves nothing like the mesenteric ischemia you have been taught to fear. There is usually no clot to find, no vessel to open. Most patients get better on bowel rest and fluids within 2 days, but a minority go on to gangrene. Today we learn the anatomy that decides where it happens, the spectrum that decides how it ends, and the findings that tell you which patient is about to need a surgeon. Let's begin. Meet our patient, a 72-year-old woman with hypertension and coronary artery disease. She has had 2 days of vomiting and diarrhea from what looked like a viral gastroenteritis. She has been drinking very little. This afternoon she developed sudden cramping pain in the left lower quadrant, an urgent need to move her bowels, and within 3 hours she was passing frankly bloody stool. She is frightened, and her family is asking whether this is cancer. Hold on to her. Here is the plan. First, the anatomy, where the colon's blood supply is thinnest, and why that decides the location of disease. Second, the mechanism, why this is a low-flow problem rather than a clot problem. Third, the presentation and the triggers. Fourth, the spectrum, because most of these patients recover completely, and a few do not. Fifth, the workup. And finally, treatment, including the 6 situations that take this patient to an operating room. Listen to the order of events because it is characteristic. First comes cramping abdominal pain, usually in the left lower quadrant and usually moderate rather than agonizing. Within minutes, the patient feels an urgent need to move her bowels, and within the first day, there is blood in the stool, pain, then urgency, then blood. The bleeding is typically modest. If a patient is exsanguinating, think diverticular bleeding or angiodysplasia instead. And notice the setup: 2 days of vomiting and poor intake. On examination, she has mild to moderate tenderness over the left lower quadrant. Her abdomen is soft, bowel sounds are present. There is no guarding and no rebound. That is what uncomplicated ischemic colitis feels like. Now hear the contrast. Fever, tachycardia, and peritoneal signs are not part of uncomplicated disease. When they appear, you should be thinking transmural infarction. That is the exam finding that changes the whole plan, and it is the one to recheck on every set of rounds. Ischemic colitis happens in predictable places, not because the disease chooses them, but because the arterial supply is genuinely thinnest there. Let's walk the blood supply of the colon. The colon is supplied by 2 arteries. The superior mesenteric artery feeds the right side through the ileocolic, the right colic, and the middle colic arteries. That covers the cecum, the ascending colon, and the proximal transverse colon. The inferior mesenteric artery feeds the left side through the left colic, the sigmoid branches, and the superior rectal artery. That covers the distal transverse colon, the descending colon, and the rectosigmoid. 2 territories, and they have to meet somewhere. A watershed is where 2 arterial territories meet at their far edges. The splenic flexure is the junction of the superior and inferior mesenteric supplies. That is Griffiths' point. And in a meaningful minority of people, the connecting marginal artery there is thin or absent altogether. The rectosigmoid junction is the meeting point of the inferior mesenteric and internal iliac supplies. That is Sudeck point. Both segments sit at the end of 2 arterial trees, so when perfusion pressure falls, they feel it first. So most ischemic colitis is left-sided at the watershed zones, but about 25% involves the right colon, and that group matters disproportionately. The right colon is superior mesenteric artery territory, the same artery that feeds the small bowel. So right-sided ischemic colitis can be the visible edge of a larger superior mesenteric artery problem. Those patients have higher rates of surgery and higher mortality. When the disease is on the right, look harder at the superior mesenteric artery. Now the part that separates this from acute mesenteric ischemia. In most cases of ischemic colitis, nobody ever finds an occluded vessel. The problem is flow, not obstruction. Follow the cascade. Something drops perfusion, hypotension, volume loss, low cardiac output, a vasoconstrictor, or a local change in the mesenteric vessels. Colonic perfusion pressure falls, and the colon starts from a disadvantage because it receives less blood per gram of tissue than any other part of the gut. The watershed segments cross the ischemic threshold first, and within those segments, the mucosa fails before the muscle does. The mucosa is farthest from the serosal supply and has the highest demand. That is why these patients bleed before they perforate. Think in layers. The mucosa has the highest metabolic demand and sits farthest from the vessels running in the serosa. It dies first. And when it sloughs, the patient passes blood. The submucosa swells and bleeds. And that submucosal edema is exactly what produces the thumbprinting sign we look for on imaging. The muscularis and serosa are involved only when ischemia is transmural. That is the gangrene group. And that is the stage at which the abdomen finally becomes peritonitic. The layer tells you the severity. Here is where it comes from. Systemic hypoperfusion is the big category. Sepsis, shock, heart failure, arrhythmia, dehydration, and hypotension during hemodialysis. Drugs matter. Vasopressors, cocaine, amphetamines, digoxin, surgical causes, especially aortic surgery where the inferior mesenteric artery is ligated. Local causes, an obstructing mass downstream. And in younger patients, think about strenuous exertion, long-distance running, and hypercoagulable states. In many cases, no trigger is ever identified. And that is normal for this disease. Let's check her against the model. She is elderly. She has atherosclerotic disease. And she has had 2 days of vomiting and poor intake, which means she is volume depleted. That is a fall in perfusion pressure. Her pain is in the left lower quadrant. Then urgency. Then blood. Her abdomen is soft with no peritoneal signs. So which segment? Left lower quadrant pain points to the rectosigmoid watershed at Sudeck point, or the descending colon. And a soft abdomen says the ischemia has not gone transmural. Here is what makes ischemic colitis different from almost everything else on the acute abdomen list. It is not one disease with one outcome. It is a spectrum. And the majority end of that spectrum is benign. Learn these 6. Reversible colopathy is the most common at about 35%. That is submucosal bleeding that resolves completely. Transient colitis is about 15%. Chronic ulcerating colitis about 20%. And that one can look exactly like inflammatory bowel disease months later. Gangrene is about 15%. That is transmural infarction, and it is a surgical emergency. Stricture about 10%. And fulminant universal colitis under 5%. Half the spectrum resolves, but 1 in 7 becomes gangrene. Here is the number that shapes management. More than half of patients resolve within 48 hours on conservative measures alone. Bowel rest, intravenous fluids, and observation. So the first 48 hours are both treatment and diagnostic test. A patient who is improving at 2 days is almost certainly in the reversible half of the spectrum. A patient who is not improving, or who is getting worse, has declared themselves, and that is when you escalate. There is no blood test that makes this diagnosis. Imaging and endoscopy do, and the choice between them depends on how sick the patient is in front of you. About the laboratory. A raised white cell count is common and tells you nothing specific. Lactate dehydrogenase, and creatine kinase can all rise, but they rise late. A normal lactate does not exclude this diagnosis, and you must not use it to reassure yourself. A markedly raised lactate in this setting suggests the ischemia has gone transmural. And always send stool studies, including Clostridioides difficile, because infectious colitis is the main thing you are trying to exclude. 2 tests. Computed tomography of the abdomen and pelvis is usually first because it is fast and safe, and it excludes other causes. Look for segmental wall thickening that respects a vascular territory. Thumbprinting from submucosal edema. And the ominous findings. Pneumatosis in the bowel wall or gas in the portal venous system mean infarction. Endoscopy is the diagnostic test because it shows you the mucosa directly. But do not scope a patient with peritonitis or suspected gangrene. In that patient you call a surgeon. 3 endoscopic findings worth knowing. First, the disease is segmental with an abrupt transition to normal mucosa, and it follows a vascular territory. Second, the rectum is characteristically spared because it has a dual blood supply from the internal iliac arteries. That single feature separates it from ulcerative colitis, which always involves the rectum. Third, there is the single stripe sign, a linear ulcer running along the anti-mesenteric border of the colon. It is relatively specific for ischemic injury. 3 diagnoses to separate. Ischemic colitis gives sudden pain, then blood in a segmental distribution with a spared rectum, and it resolves in days. Inflammatory bowel disease builds over weeks to months. And ulcerative colitis always involves the rectum, which is the cleanest discriminator you have. Infectious colitis usually has more fever and more diarrhea. And note one important mimic. Shiga-toxin producing Escherichia coli causes a right-sided hemorrhagic colitis that looks just like ischemia. Stool studies settle it. For most patients, treatment is supportive and the disease resolves. Your job is to give good supportive care and to identify the minority who are not going to resolve. Both halves matter. The bundle is 4 things: bowel rest, nothing by mouth at first, and advance as the pain and bleeding settle. Intravenous fluids to restore perfusion. And notice that fluid is not merely supportive here, it is treating the mechanism. Broad-spectrum antibiotics because a damaged mucosal barrier lets gut organisms translocate. And serial abdominal examinations. That last one is the most important thing on this slide. The examination is your monitor, and it needs repeating on every round. Beyond the bundle, go find the precipitant and fix it. Volume depletion and arrhythmia, a low output state. Reduce vasoconstrictors where you clinically can. Review the medication list for constipating and vasoactive agents. Do not give steroids. This looks like colitis, but it is not inflammatory bowel disease, and steroids do not help here. And support oxygen delivery. Oxygenation and hemoglobin matter because the problem is delivery of oxygen to a segment that is already short of it. 6 indications for operation. Bowel infarction. That is gangrene, and it is the commonest reason. Fulminant colitis with systemic toxicity. Massive hemorrhage. Failure of medical therapy after a fair trial. Recurrent sepsis that you can attribute to the colon. And asymptomatic stricture that develops later as the ischemic segment heals with fibrosis. Notice that the first 3 are emergencies and the last 3 usually are not, but all 6 mean the colon is not going to recover on its own. How do you know it is turning? 3 domains. The examination changes. New guarding. New rebound. Pain rising despite bowel rest. Bowel sounds disappearing. The physiology changes. Fever. Tachycardia. Hypotension. A climbing white count. A climbing lactate. And the imaging changes. Pneumatosis in the bowel wall. Gas in the portal venous system. Or free air. Any one of these in a patient you have been observing is a reason to call the surgical team now, rather than at the next round. And afterwards, most patients recover completely with nothing to show for it. If the initial appearance was severe, it is reasonable to repeat endoscopy at follow-up to confirm healing. Warn the patient about stricture. Obstructive symptoms weeks to months later are the clue. Chronic segmental ulcerating colitis can appear later and be mistaken for Crohn's disease. And if the disease was right-sided, think harder about the superior mesenteric artery. That patient may have larger vascular disease to address. The pitfalls. Do not start steroids. This is not inflammatory bowel disease. Do not use a normal lactate to rule it out. Do not scope a peritonitic patient. Call a surgeon instead. Do not fail to re-examine the abdomen repeatedly over the first 48 hours, because that examination is your entire monitoring strategy. Do not ignore right-sided disease. Do not skip stool studies. And at endoscopy, do not insufflate aggressively. High intraluminal pressure reduces mucosal perfusion in a colon that is already ischemic. Back to our patient. The sequence of pain, then urgency, then blood in a volume-depleted 72-year-old pointed us straight at ischemic colitis. Computed tomography showed segmental thickening of the descending colon. Sigmoidoscopy showed sharply demarcated ulceration with a completely normal rectum. Stool studies were negative. We gave bowel rest, fluids, antibiotics, and we examined her abdomen every shift. Her bleeding stopped within 36 hours. She went home on day 4. 5 things to carry with you. 1. This is non-occlusive low-flow disease. There is usually no clot to remove. 2. The watershed zones fail first. The splenic flexure at Griffiths point and the rectosigmoid at Sudeck point. 3. Pain, then urgency, then modest bleeding is the characteristic sequence. 4. The rectum is spared, and that is your cleanest discriminator from ulcerative colitis. 5. More than half resolve within 48 hours. And serial abdominal examination is how you find the 15% that will not. These are the sources behind today's teaching. The American College of Gastroenterology Clinical Guideline on Colon Ischemia. The New England Journal Review of Mesenteric Ischemia. The World Society of Emergency Surgery Guidelines. The British Medical Journal Clinical Review of Ischemic Colitis. And the Clinics in Colon and Rectal Surgery Review of Management. Thank you for watching. Verify everything here against your own institutional protocols before applying it at the bedside.